What is the basic defect in porphyria? What is the basic defect in porphyria? What is the problem? Why does because I am discussing hyperbilirubinemia, means bilirubin level will be increased. So you have already been told about porphyrias and you have answered also. What is the defect in porphyrias? বলো 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 বলতে থাকো, ভুল বলো, কোনো ব্যাপার নাই। ক্লাসে দুটো একটা ভুল না বলে শিখবে না। আমি চাইছি ভুল বলো দুটো একটা, কিন্তু পরীক্ষাতে তুমি ঠিকঠাক করে যেন বলো, লেখো। বলো। হিম সিনথেসিস ডিফেক্টিভ। হ্যাঁ, হিম সিনথেসিস ডিফেক্টিভ তো। ইয়েস, দ্যাট ইজ হোয়াট ইজ হিম সিনথেটিক পাথওয়ে। কারেক্টলি সেড, একদম ঠিকঠাক বলেছো। See, it is basically because of the defective enzymes in the heme synthetic pathway. And today, what I will be covering is just after the heme catabolism has been done, defects in the bilirubin pathway. So, what is bilirubin? That by this time you have a rough idea. Now, in abdomen, has the liver been covered? Anatomy? Which part of abdomen has been covered so far? Abdominal walls. See, the basic problem is that if you don't have a proper anatomical knowledge, then it will be very difficult to understand, because the basic difference between a non-medical person and medical person, they will also be knowing this thing, but they will not be able to go into the depth. And once you know anatomy, physiology well, then you can correlate with biochemistry, because we will be dealing today what is going on in the hepatocyte. And hepatocyte is the basic unit of liver. So, should I tell a little bit of anatomy of liver and the surrounding areas related to hyperbilirubinemia? Otherwise, how will you know? You know liver, where it is situated, what is the anatomical position in the abdomen. Have you seen the cadaver in the cadaver? So just I am telling you, see, if you divide abdomen just for, this is briefly I will cover so that you understand. Basic objective is to know the obstructive jaundice, site of obstructive jaundice. So anatomy has been, this abdomen has been divided into 9 different parts. One is right hypochondrium, then epigastrium, then left hypochondrium, then right lumbar, then left lumbar, then umbilical region, and then hypogastrium, right iliac, left iliac. So liver is present in the right hypochondrium covering epigastrium up to left hypochondrium. This is the actual position of the liver. This is the liver, human liver. Liver is having 5 surfaces. One is superior, one is inferior, one is anterior, one is posterior, one is right lateral. And there are borders also, superior border, posterior superior border, posterior inferior border, right lateral border. There are 4 borders. And if you look at the undersurface, that is inferior surface, you will see that gallbladder, bile duct, all these things are there. This area is important anatomically to know how actually bile passes from liver through hepatic duct to gallbladder and through cystic duct to common bile duct. Without knowing that part, you will not understand, because formation is taking place here, now it is going out. Now that part is to be understood well. Once you read anatomy, then I think things will be clear. See, again I am showing it very casually and schematically. See, this part I have shown. From these areas, you see bile is formed. And then this bile comes through this duct to gallbladder, where it is concentrated, and through cystic duct to common bile duct, it enters into the second part of the duodenum. Through ampulla of Vater, periodically with fatty bile, this bile enters into the second part of the duodenum. Okay. So if you do a cholangiogram, means if you put a dye at this place, if you inject a dye, if you insert an endoscope and insert in this sphincter of body, if you push a dye, the dye will move along the track of the biliary tract and you will get a cholangiogram. This you will see and you will be able to note where the block is. If the channel is fully normal, whatever you are seeing is basically the biliary canaliculi. From the bile is coming from the liver through the hepatic duct, through cystic duct, through common bile duct to the second part of the duodenum. Can you see it? Now you see here you see. This is called endoscopic retrograde cholangiopancreatography. Means not only the liver you are seeing, you are also seeing the pancreas. This anatomical part is required because you will be in the clinical setting, ERCP is done routinely. If there is any problem related to, LFT abnormality or diseases of the pancreas or the liver or the biliary tract itself, I am showing it only to have a little bit orientation to the clinical subject, otherwise it will be very dull and boring. So if we cut the liver, if we make a histology, we will find the smallest functional unit, that is hepatic lobule. That is a hexagonal structure, and a hepatic lobule contains millions of hepatocytes. And we will be dealing in this class what is going on in the hepatocytes. So if you look at the structure here, you see there is a sinusoid, there is biliary canaliculi, and I have just enlarged this figure here. This is the hepatocyte. These are the hepatocytes. And you can see there is the sinusoids and there are the biliary canaliculi here. You see the hepatocyte here. These structures are biliary canaliculi. Means bile is formed and that bile passes through the biliary ductule into the biliary duct. So, in a better way I am just representing it. These are the hepatocytes you can see. That's why what I am telling you, why anatomy is required. Without knowing the histology, it will be very difficult to understand this part, because this is formed, the hepatocytes are having two surfaces. One is having a sinusoidal surface through which portal vein and hepatic artery is giving supply to the hepatocytes. And the bilirubin, which is of our interest today, will be released into this biliary canaliculi to be drained into the bile duct finally. So, this bilirubin is formed here in the hepatocytes. Through the blood, this unconjugated bilirubin will to this sinusoidal surface, and from the sinusoidal surface, it will enter into the hepatocyte, and then the conjugation will take place. After that, on the canalicular surface, this will be excreted in the biliary canaliculi. So this is what we are interested in. As you can see, schematically I have shown that finally bile will be released into this system. Write down this part. All these things are not required. You just understand, and I will ask some part to note down. So what is bilirubin? Only write down one part. Bilirubin is a yellow or yellow colored compound produced from normal catabolic pathway of heme. That's this much. You have explained, many of you have explained this tetrapyral ring, how bilirubin is formed, all these things you know. Now, what is the fate of RBC? every cell is having a lifespan, almost, without fail. Because every living being has a life. The life of RBC is 120 days on an average. So at one point of time, the RBC will age like human being. So these are called senescent RBC, means aged RBC. That aged RBC are to be removed, and new RBC will be formed by the bone marrow. Who will remove that senescent RBC? How? And how it will recognize that it is a young RBC, fresh RBC, or it is a aged RBC? So that is done by the reticuloendothelial cells. How reticuloendothelial cells will know that whether it is an aged or whether it is a young or whether it is a newly formed RBC? See, if a newly formed baby is formed, you know the morphological features that is newly formed baby. If I am aged, because I am having some marks, I am having grey hairs, I am having the skin which is not as good as you, it is lax. So there are some morphological appearances by which aged person can be detected. Same thing happens with the senescent RBC. So ultimately, when the RBC is broken down, three things are obtained. One is globin, that is degraded into amino acid and it goes into the amino acid pool. Porphyrin is broken down into the bilirubin, and iron is enters into the iron pool also. So the mechanism how this RBC is removed, write down one part, erythrophagocytosis. This is done mainly by the macrophages of the spleen and also in the liver and bone marrow. This process is called erythrophagocytosis because they are phagocytosing that RBC, that dead RBC. So how they recognize? Because they recognize just like human being or any aged person by senescent markers. There are markers. So after phagocytosis, then hemolysis only occurs. So these are the changes. See, on the phagocytes, there are sensors. They sense through intermolecular interaction that it is aged. And you can see any aged person will have a decreased metabolic activity. Same is true with RBC. So first they will lose the aspartate aminotransferase and esterase activity that is inside the cell that the phagocyte will not be able to recognize. Now there will be loss of morphological structure. The morphological alteration will be there. There will be decreased cell volume, change in the cell shape, and that is a signal to the the phagocytes that this is an aged RBC. This part is not written in your book. Surface modulation, oxidative stress damage. So these are recognized by the macrophages, and many other changes are there. It's not a simple thing. So through that, site of bilirubin production, note down. Free porphyrin is degraded in the RE cells of the spleen, bone marrow, and liver. These are main three organs. You write down in which organ it is degraded. Clinically, you can see the degradation from heme to bilirubin in a fair-skinned person. Those who have sustained a hematoma, that means blood is under the skin or near the subcutaneous tissue, that area will be red at the time of formation of heme. Now, in course of time, it will change its color to purple, then it will be black. Many of you have seen this thing. So that is actually basically from that hemoglobin to bilirubin formation is occurring, and it is getting out by the reticuloendothelial cells of the tissue spaces. So catabolism of heme from all proteins to a heme oxygenase microgenomic system that you have written. In clinical practice, I have seen one case of bilirubin in CSF, cerebrospinal fluid. there was one subarachnoid hemorrhage case and I made a lumbar puncture. In lumbar puncture class, I will discuss in detail and you will be able to diagnose this case without doing a CT scan. And that's what I did during 1985, 86 when I was an intern. CT scan was not there. By doing a LP, I diagnosed this case. This was a case of subarachnoid hemorrhage, not intracerebral hemorrhage. So that I will show again during, if I take the CSF class. This is a short note for you. Note down, write down. Heme containing proteins, a short note, 5 marks. So write down all these things. And what are the functions? These are common Viva questions I have seen. This is written in the book, but write down or you take it from the book itself. Read it from the book. See, hemoglobin, myoglobin, cytochrome P40. Cytochrome P40, I am telling you, this is one important part with respect to pharmacology. Genobiotics. What is genobiotic? Anything, any foreign material, foreign chemical which is not normally present. বা ছবি তুলে না বসে বসে পড়ো লেখো ইউজ করো আমি ছবি এগুলো দেখে ভিডিওতে দেখতে পাবো কোনো অসুবিধা নাই লেখো লেখো লেখা হাতে লেখে মুখস্থ করার চেষ্টা করো ট্রাই টু মেমোরাইজ see if you take a drug that is a genobiotic if you take a chemical along with the food that is also a genobiotic and these genobiotics needs to be detoxified so one of the major function is hydroxylation. So this is done by cytochrome P450 in the liver. Catalase, tryptophan pyrrolase, and those who will be answering better, they might be asked what are the heme-containing enzymes. So at least you write till one part that is tryptophan 2,3-dioxygenase. MCQ question may be there also. Because all examiners are not same, at least 2 or 3 difficult questions will be there. So this part you have written, this part you know, I am not going into the depth in details at all. Only thing it is done is the reticuloendothelial cells, don't forget it. The conversion of bilirubin, this part also you know, this all you have written. Only look, note down here, what does bilirubin reductase does? This is basically the reduction of methylene bleach here. You see it's a double bond here and that is getting a single bond. That is a reduction. Bilirubin is sparingly soluble in water, write down, because it doesn't have much of hydroxyl group, polar groups. And that's why bilirubin is sparingly soluble in water. And that is the reason why it needs to be transported by albumin. In order to make it soluble somehow, so that it can be transported. Otherwise, it is a lipophilic substance. So, bilirubin as such is a lipophilic substance. Binding with albumin is required to make it soluble. Albumin is also a colloidal molecule. It's not in true solution, but there are too many hydroxyl groups or polar groups are there. They bind. Albumin is basically a donkey molecule. It carries many things, and one of them is also bilirubin. So it carries the unconjugated bilirubin formed by the reticuloendothelial cells to the liver through the sinusoidal surface. Remember that structure. One molecule, note down, one molecule of albumin can bind 2 molecules of bilirubin, and there are 2 sites. One is high affinity site, one is low affinity site of bilirubin, and this is clinically important from pharmacological point of view. Why? We know that it can bind up to 25 milligram of bilirubin per 100 ml of plasma. The clinical relevance is that at times you will take some drugs, antibiotic, aspirin. These drugs will compete with bilirubin to occupy that site. Naturally, bilirubin will not be allowed to occupy that site, and bilirubin level in the blood will be falsely high. And you will falsely, erroneously diagnose that this patient is suffering from hyperbilirubinemia, which is not a fact. It is due to drug. So that is the clinical relevance. So, as I told you that after the bilirubin has entered, comes into the liver, it will reach the sinusoidal surface. That part I have shown it in the beginning. And in the liver of cell, that is hepatocyte, now coming to the down, narrowed down to hepatocyte. No more anatomy. So, three phases are there. One is uptake, one is conjugation, one is secretion. That also you are a little bit aware of it. Here you biochemistry part is there. This is large capacity. This is taken up at the sinusoidal surface by a large capacity saturable facilitated. This is facilitated and release is active transport. Try to understand the difference between the two. So, uptake is a large capacity saturable facilitated transport. It is not a rate limiting step. Its metabolism depends, uptake depends on how fast it is cleared from the hepatocytes. Once the bilirubin is internalized, just like glucose, once it enters into the cell, it gets converted to glucose 6 phosphate so that it cannot go out. Similarly, once the bilirubin goes in, it binds to the cytosolic protein, that is glutathione S transferase. When we are students, it was said to be ligandin, so that bilirubin cannot come out from the hepatocytes. Now it will undergo conjugation. So if it is not undergone conjugation, it is a lipophilic substance, so it will remain soluble in the lipid. So it gets conjugated with glucuric acid, that most of you know. I am not going into the detail, only remember the enzyme UDP glucuronidase transferase enzyme. Important point is that it is not normally measured, but you will definitely see in your clinical practice a few patients who are suffering from mild deficiency of glucuronidase transferase, and for that a genetic study is required. Gene identification of the glucuronidase transferase, not the glucuronidase transferase activity. So this part you know, this part you know, this I told you, that is a saturable facilitated transport system. This is active transport in the biliary canaliculi that I told in the beginning, and this is done by a multi-specific organic anion transporter. Write down how it is transported. It is not only bilirubin but other anions. It is multi-specific. It is not bilirubin specific. And it is located at the plasma membrane of biliary canaliculi. Bilirubin is excreted in the form of bilirubin digluconate mostly. That is the most soluble form. You see here, again I am showing it to you here. This cytosol, it is taken up. This is the biliary canaliculi surface. So, through active transport, this is excreted into the biliary canaliculi. Now, see, look down here. Bile acid also from cytosol surface, it enters into the biliary canaliculi, and this is anion transporter protein. Bilirubin and organic cytosides, and that is multi-drug resistant protein 2, and it enters into the biliary canaliculi. So there are several different proteins are there in the hepatocyte. This is a simplified form. Here, disease, bilirubin plus albumin uptake. If there is a problem in the uptake level, then bilirubin will be there, and that will be unconjugated bilirubin. If much more than the capacity of liver, of amount of bilirubin reaches to the liver will not be able to take up. So that will be an unconjugated bilirubin, and that is what exactly happens in hemolytic anemia. When there is a huge amount of hemolysis, a huge load of unconjugated bilirubin will reach to the liver surface, and liver will not be able to take up also that much. When that happens, or if there is a defect in the uptake transport protein, then you will get a unconjugated hyperbilirubinemia. Once it is taken up, there will be conjugation. And neonatal jaundice, many of you have answered or know also. So, if there is a conjugation defect, we get usually this type of cases. One is neonatal jaundice, which you will be seeing in the clinical practice. This is a little bit common. Toxic jaundice can be due to many toxic substances. Crigler-Najjar syndrome, hardly anybody sees. Gilbert syndrome, you will get at least 1 or 2 cases, maybe 2 cases or 1 cases in 1 or 2 year time. If you get a good number of patients and if you are vigilant enough, then you will be able to detect it. And then if there is a secretion defect, then that is called Dubin-Johnson syndrome. So this is a conjugated bilirubin because conjugation has taken place. So if at this level there is a problem, so that is called conjugated hyperbilirubinemia. This part again you have written. One point I want to tell that since you have not been told about the intestine, so enterohepatic circulation you will not be knowing properly without knowing that part. So bilirubin, once it is formed, this liver, it will be excreted to the bile. Through the bile, it will undergo conversion into urobilinogen, and the same urobilinogen in the feces, it is called stercobilinogen. That stercobilinogen will be excreted in this with the stool. Only a small part is reabsorbed and recirculated and re-excreted. That is called enterohepatic circulation. So this is the actually structure. See, this is what is enterohepatic circulation. If you know the anatomy part, then only you will understand this thing. See, from the terminal ileum and the colon through the superior mesenteric artery, mesenteric vein and the inferior mesenteric vein, they will combine along with the pancreatic vein, the cystic vein, gastric vein, they will form the portal vein. And actually, bilirubin reabsorption takes place through the superior mesenteric and inferior mesenteric vein. So, these again entering into the liver. So, this is enterohepatic circulation, and a part will be excreted into the bloodstream. Some which cannot be metabolized here, it will be excreted through the venous system into the main circulation, through the inferior vena cava. So, that is how it enters into the bloodstream, and that is how it enters into the kidney, and urobilinogen comes into the urine. That is the actual mechanism. Now, if there is a less amount, then it will not be detectable. But a huge amount of urobilinogen is absorbed. So, liver will be able to use it as much as it can. Rest it will throw it into the circulation. And then only that excess amount of urobilinogen will come and it will appear in the urine. So, summary, this you know by this time: formation, transport, conjugation, excretion, recirculation. Absolute clinical term I have come now. This is what you have to diagnose. Write down predominant conjugated hyperbilirubinemia is found in obstructive, number 1. Cause number 2 cause is hepatocellular jaundice. One day I told that I have not covered all these things. A small part I have told to the nursing student of first year in 2023, and I showed one LFT report. And believe me, within 5 seconds time, one nursing student told this is hemolytic anemia, hemolytic jaundice. So you must be able to know all these things in detail. Predominant unconjugated hyperbilirubinemia, hemolytic jaundice. And that is the reason I am telling you, without seeing the patient, you must be able to diagnose. Only conjugated bilirubin appears in the urine because it is soluble. Unconjugated bilirubin is not found in the urine. So bilirubin present, bile pigment present means it is conjugated bilirubin. It is not unconjugated. So this part is not written. Again, I am telling you this. You try to understand. Catabolism in heme produces bilirubin. Now, how much and in what way? So if you look at the RBC count, so different books write different figures. USA book write one figure, UK book writes one figure. If you take 5 books from 5 different authors, you will get 5 different figures. If you get bilirubin level from 5 different countries, 5 different figures. And in India, we don't have any figure. And it is not possible. We usually copy. All the figures which you will be seeing as normal level has been copied. Each and every parameter. There is no normal value for India. Even it is not possible for to make a normal value for West Bengal also. Because Darjeeling is geographically different than Sundarban. So we interpret the data as per Western figure where we are committing a mistake. You must understand that thing. You must understand that our food habits, our culture, our behavior, our food material, everything is quite different than from US or UK. So we cannot take their value. We can get a guideline that much. That's it. But you have to use your own brain to decide whether what he will do. Is that figure, whatever the foreign people are saying, are correct? And if you look back the history, you will see that there is a change. There are changes. You can also make a change. I have made a change. I will show it to you. So you see here, so male and female, there is a difference. So average I have calculated to be a 4.8. It's Davidson book, which is an UK book. Achha, are you tired? Are you tired? Because this requires understanding. If you are not interested, because I will not be able to cover this, then at least 10-15 minutes you wait. Tomorrow I will take the next class. 10-15 minutes you just wait. These are the figures which are not written in your book. I have used my brain and I have calculated it for you. You just note down. Tomorrow you will be able to diagnose this case. You just listen. You listen, there is no way out. I can finish this class in 15 minutes time, I am telling you. Any class, whatever is assigned to me, be it practical, be it theoretical, I can cover in 15 minutes time. But I am not doing that thing. You must have some better idea. And you must leave this institution with some more knowledge. That's my idea. You ask this thing, I am telling you, in this entire college, entire hospital, nobody will be able to tell this thing. Nobody will be able to tell this thing how. In our SOMS central lab, they are giving another figure. So all the figures are not matching. So note down this thing, 1 cubic millimeter of blood that will be expressed is equivalent to 1 microliter that you are doing in the practical. So 1 ml is 10,000 microliter, 10 to the power 3. 1 liter is basically 10 to the power 6 microliter. Now you see our college figure. So hemoglobin 12 to 16, reticulocyte count is this much. Now again this figure I have shown. Now see what is going on here. You see this part I have seen, so 4.8 and 1 liter blood is equal to 10 to the power 6 microliter blood. So that means adult body contains 5 liters of blood. So we are having 24 into 10 to the power 12 RBC. 1 billion is equal to 100 crore. Human adult blood contains 24,000 billion RBC. Billions RBC. Why is this figure important? Because normal RBC destruction rate per day is nearly 200 crores. Per day normal RBC breakdown. That means this much amount is produced also. So that means 1/120th of RBC is being destroyed. 1 gram of hemoglobin right down yields 35 milligrams of bilirubin. Human adult forms 250 to 350 milligrams of bilirubin per day, and this is principally derived from hemoglobin. Again, normal level of bilirubin. There is a variation from book to book. Still, I will advise you to take it, what is written in the Harper's book, 1 milligram as the maximum upper limit. Beyond that, you be a little bit suspicious that the patient is not having a normal bilirubin level. Write down the definition. What is jaundice? Jaundice is a clinico-pathological condition. Although we have said it is more than one will not produce yellow color discoloration of the sclera. So you will not be able to diagnose. Although there will be hyperbilirubinemia in the blood, but that will not be clinically detectable. So the bilirubin level must be around more than 2.5. Otherwise, it will not stain the sclera. Sclera is the white part, and hyperbilirubinemia is found only in the sclera. I will show you. I will show it to you. So it is not only sclera, but mucous membrane, hand, soft palate, and palm. These are all will be stained yellow. And jaundice is a common manifestation of patients with liver diseases. And the characteristic symptom, patient will come because they are having a yellowish discoloration of the skin or urine. So this is how now coming to the clinical part. Each and every patient, make it a point that you examine the eye. How will you do it? You ask the patient to look down while you drag the lid upward. You see the maximum amount of sclera which will be visible. And why this upper part? Because if you look at the eyes of many persons, that some palpable facial area is exposed to the environment. So dust and dirt is there. So there will be a color difference between the upper part of the sclera and the part which is being exposed to the air, particularly as we age. There is some amount of dust and dirt accumulation through the environment. So that will discolor. Those who smoke also. So because of the continuous smoking color, the color will change. So you make it a practice that you note down the color of the sclera. There is quite a good amount of variation. Once you make your eyes as, yes, in this age, this is normal, this is not yellowish discoloration, then only will be able to diagnose this case early. This is a very severe case. This is not early case. So many persons also, when the eye is actually yellow, then if you drag from any side, you will be able to see it. Why sclera is taken? Because that is the whitest part. And where if a slight amount of stain is there, yellow elastin tissue is there, that is having a predilection for bilirubin. So that is the reason why this part is shown. And if you take a normal serum, I told that I will draw the blood and you will see the serum. You see the serum color will be normal like straw color. And jaundice serum will be looking like this, reddish to orange yellow. If the bilirubin level is very high, obviously it will be orange colored. And from this serum, you will have an idea to what is the degree of the jaundice in a particular patient. It may match, it may not match. And when it will not match, that also I will tell you tomorrow. So these are the things which I will discuss tomorrow, not today. You are already fed up. Big emphasis, write down this thing. And if you cannot do if you cannot interpret a report of LFT, I accept it as a moral failure of me to teach you. You must be able to diagnose from the LFT without seeing the patient. I repeat, if you, after attending my tomorrow's class, if you cannot do this thing, I humbly surrender before you that I have failed miserably. That's it. From the report, you will be able to diagnose. You need not require to see the patient. Patient will tell many things. Their relatives will say many things. But you will not yield to that pressure. Because basic science is with you. Basic understanding is with you.